A and B are congenital bleeding disorders, and we currently have a number of very effective therapies which can be used both to treat and prevent bleeding. And really in patients with severe and some with moderate hemophilia who are really at high risk for spontaneous and traumatic bleeding into the joints and muscles, as well as potentially life-threatening bleeding, the standard of care has been to use preventive therapies. And so, prophylaxis was a big paradigm shift a number of now decades ago. And until recently, the treatment has been with intravenous clotting factor, anywhere from 1 to 3 to 4 times per week, in order to prevent most bleeding and allow patients to have fairly active, although still limited lifestyle. And so this depends on regular access to healthcare, remembering to get their factor, remembering to infuse the factor, the time spent, and particularly even impacting on school, work, travel, family planning, because although it's very effective, there is treatment burden, and it's something that someone always has to be thinking about. Also with the factor prophylaxis, there's what we call troughs and peaks. And so depending where the person is, with their factor levels at any given moment, it could impact, decision-making in terms of, do I go to Disneyland, or do I go on this hike, or, what can I be doing at this moment? And then in the past several years, then for hemophilia A, there's a new prophylactic medication that's a factor VIII mimetic. So it's not clotting factor, but it replaces the function of factor VIII. It's called emicizumab, and it's given subcutaneously 1 to 4 times per month. And so this has taken away some of the intravenous burden and offers great hemostatic protection. However, it can still have breakthrough bleeding and still requires that same diligence in terms of having access to the treatment and following up. So this is sort of the preface for the gene therapy as a paradigm shift, because with gene therapy, the goal is a one-time infusion of AAV vector that will allow the liver to produce factor VIII or IX at sustained levels over a period of time. And so although there will be actually probably more intense clinic visits and follow-up early on, before and for several years after the treatment, the goal is that then the people who receive this will not need to have regular access to the clotting factor or other hemostatic treatments, and they can sort of depend on sustained level of hemostasis. So, some people use, the term of like hemophilia-free mind, so that, they've had the treatment and, they don't have to be thinking about hemophilia and, access to care every single moment. So I think that's the big thing that sort of makes the paradigm shift.